Buenas tardes. Soy Susana Lorenzo. Lo primero es, voy a moderar esta mesa en la que ahora les presentaré a Peter Lackman, al que tenemos que dar muchas gracias por venir a Madrid. Han tenido las instrucciones para la traducción y, por favor, las preguntas, en caso de que las quieran hacer, es a través de la app. No voy a estar mirando WhatsApp, voy a estar mirando las preguntas que hagan a través de la app. Entran en la sesión, que pone, ahí sí que pone auditorio, y ponen las preguntas y yo se las trasladaré a Peter. Es un honor presentarles al doctor Peter Lackman. Es pediatra y un referente internacional en seguridad del paciente. Fue CEO de ISQA, impulsando su liderazgo global en calidad y seguridad. Actualmente dirige el Chiani Global Interprofessional Patient Safety Fellowship en la Patient Safety Movement Foundation. Desarrolla su labor en el ámbito internacional y ha desarrollado programas de liderazgo clínico en el Royal College of Pediatricians en Irlanda, asesora iniciativas de mejora de la calidad en Europa, en África, en India, preside consejos asesores internacionales como CAO en India y FLACUM, que se ha presentado esta mañana en Bélgica, forma parte de la Junta Directiva de Acquire en África, en Kenia, y es editor de los Oxford Handbooks de Seguridad del Paciente, de Liderazgo y Gestión Médica y más recientemente del de Mejora de la Calidad Asistencial. Con ustedes para la conferencia Construyendo un Sistema Sanitario Más Seguro, ¿cómo lo hacemos? Please welcome Dr. Peter Lackman for his keynote, Building a Safer Healthcare System. What will it take? The floor is yours. Thank you.
Gracias. Hola, Madrid. When I was invited, and after listening to the message from you, Maria Fernandez, I'm saying, what am I doing here? Why do you need someone from outside to tell you what to do? Because you're already doing a lot. You may wonder why we started with Schubert's String Quintet. Volume up. Can I have the volume? Just look. You've seen human factors in action. Making beautiful music. The tools, the tasks, the environment, the organizational culture of the group, all coming together. I want you to think of this as I talk through this today. But we can't listen to the whole piece. We're here to talk about building a safer system. Why do I not say a safe system? You know, the WHO say we must get zero harm. But that's impossible. Zero harm's only possible if you don't go to hospital. Because we're always going to have some harm. But we must pursue the safer system. So I'm going to take you on a journey today. But the journey actually started over here. Over here. In the Roman times. That's when patient safety started. Not 20 years ago. It's a long history of patient safety. To the Industrial Revolution, we are living in these last three ones. Starting with the the report that came out from Lucien Leap and company, and I just want to pay homage to Lucien Leap, who died a month or two ago, who was the starter already of the movement in patient safety, and who I was privileged to meet and work with. And then we had the age of quality control. That's the age we've been in now. And then the WHO finally accepted that this is important, and now we are in the age of trying to make improvements, and you can look at that. So this is the first kickoff point from the USA to Earth's human. 100,000 Americans, that's one jumbo jet crashing every day, dying from unsafe care. Unfortunately, they're still dying from unsafe care. So what's in this black box of patient safety? What's in the box? And there are 3 questions I've taken from SECA that we need to look at. Why is it important? That's the most important question. Why is it important? Sorry, I've got to go back. What are the challenges? And then how do we be safe? Most of what we do is talking about the what and how. But the most important thing is the why. The first is the people. Who are the people? They're the families. It's trying to bring forward for some reason. The families. The extrinsic things. 8 million deaths. You refer to the number of deaths from poor care. That's in the lower middle income countries. Not counting us. Then there's the prevalence studies. Safety, 1 in 10, but this one, the last one from Bates, that one, 2023, a quarter of the patients in Massachusetts being harmed. And then there is the goals set by the WHO that we need to do. And the report that came out, and at ISQA, the latest report came out, where they have 150 countries reporting that only 30% are on the way to have goals. Spain, of course, is one of them, but it's really hard. And I was fortunate to edit the World Patient Safety Goals for this year. And as you can see, we have set 5 goals. Now, these are for children and neonates. They're also for elderly, because elderly and neonates are very similar. They get the same kind of things, surprisingly. You have to engage children and their families. As you can see, you spoke about that. And then the 3 big ones, medication, infections, and diagnostic safety. The 3 big ones. And then, of course, there's some special for neonates particularly. I encourage you this year, for all of you, the one thing you do when you leave here is download these goals. And in your hospital, your clinic, or wherever you work, implement them. Because that can make it safer for the 1 highest risk. The 2 highest risks are the very young and the very old. And the goals are written in order for you to do this. And of course, there's another extrinsic one. It's the law. Did you know it was the law to be safe in Spain? However, I've noticed many things the citizens do not obey in Spain, and one of this is the law. Like most countries, the law is not the solution. It's just a guide. And then there's the intrinsic. What's the intrinsic? For the doctors or nurses in the room, how many of you have experienced an adverse event or a near miss? Could you put your hands up? Yeah, hands. And some will be not too scared to put their hands up. This is my story. You're going to hear two stories. When I trained, and in my first week of being a senior resident, or a resident, first week being of a resident after a junior resident, we had a diarrheal room, and the doctors in the front had to assess whether the child had diarrhea, how severe the diarrhea was, and whether they needed this sodium chloride. And the doctor was seen 30 to 40 a day, says to the nurse, I need 5 mils of sodium chloride. The nurse gives him a vial, or gives him the injection, and he injects, and the child dies. And I am a young doctor who have to tell, this is in 1984, I had to tell the parents we killed their child. That's why I'm standing here. This is what the doctor got. 5 mils of sodium chloride. They were kept side by side. The only difference is the one has got red writing. The doctor lost his job. The nurse lost her job. Manslaughter for a human factors error. But in 1982, no one knew about human factors in healthcare. So that's why I'm here. So we've all got a story. So that's the why. Why are you sitting here today? You could be sitting somewhere else. So we all have our why. So you have to, the first thing to make it safer, you have to find out the why. Why are people in healthcare? And they're not there to harm people. So you have to connect with their why. So we've all been second victims. And I've been very pleased to have been working with the COST group, and it's been led from Spain. Jose, he's not here, Jose Miller, he's not here today. But we've all been second victims at some times in our career. And that is often the why. So the why is the most important thing. And this is something we forget when we tell people what to do. We don't connect why they should do it. And everyone has a different why. So that's lesson number 1. The second one is, what are the challenges? Now, you've heard them already from the 2 previous speakers. The first big challenge, and this is in children and in the elderly, they go through different developmental ages, they become dependent, the epidemiology is different, and they're affected by the social determinants of health. I'll come back to these. But these are the 4 Ds, written for children, but they also affect elderly. Just remember the 4 Ds. If you want to know what's the problem in patient safety, look at this paper on the 4 Ds. And then there's the slippery slope in deterioration. So sepsis is a big thing, is that people fall off the cliff very quickly. And then what do, we create rescue teams. Why? Because we haven't predicted ahead of time. We're good on reaction, but not on prediction. So I'll show you later on how we can predict. And this is a very important, this comes from Australia. It's a very important discussion on how you deal with sepsis and situations where the patient suddenly deteriorates. They just fall off the cliff, and then it's too late. Then we have climate change. And climate change, for patient safety affects the poor, the destitute. Does the rich as well, but less so. We have to include climate change as part of our patient safety efforts, and we have to start counting carbon in our hospital. How much carbon we're using, because that's going to affect us. So climate change is very important. Then inequity. It has been shown that people from lower incomes, lower socioeconomic status, different ethnicities have higher degrees of patient safety events when they come to hospital. These are two papers. And the social determinants are the key one: our cultural competence, our implicit bias, and the structural racism or prejudices that we have. You know, if you go to a hospital in America, your outcome is dependent on the color of your skin, whether your ancestors were slaves or not, even if you're Barack Obama. No matter who you are, the color of your skin tells you how you're going to do. I'm sure that's similar over here, where you live, where you come from. And then you referred to earlier the non-communicable diseases. Our hospitals were built for infectious disease, not for communicable disease, not for non-communicable. Elderly people should not be in hospital. They will fall. They'll get dementia. So what we do, we have a falls program. We have a dementia program. Not a dementia, a delirium program. If a person who's used to staying in their own home is admitted to hospital, they will get something wrong, pressure ulcers. And then we have programs to prevent them. So chronic care is a new challenge for us. AI, a solution and a challenge. It's a tool that's going to help us, particularly in diagnostics, but it's only a tool. It's going to be a problem if we haven't worked out how to use it safely. And then digital and telehealth. How are we going to use that safely? These you already heard from Maria Fernandez. Thinking about how can we use this safely. How do you make your diagnosis safely if you don't have the person in front of you? During COVID, suddenly we had a lot of telehealth, but no safety measures. We just don't know how unsafe it is or safe it is because we haven't worked that out yet. But the biggest challenge is how do we get smart people? Who do I call smart people? That's clever, intelligent people, doctors and nurses, to do the right thing the first time, every time. You'd think it would be easy. After all, when I went to medical school, the first day they said, "You are the cleverest of them all." It's difficult to get into medical school. The same in Spain. People have to compete to get in. You have to have high grades at school. But how do these very clever people fail to be safe? I can't understand it. Why doctors don't wash their hands. I can't understand it why doctors do not prescribe accurately 100% of the time. Many reasons I know why. They are clever people. Why don't they do it? And I do not understand why patient safety and quality is still a niche market in healthcare. Doctors and not so much nurses, but doctors particularly, and I can speak as a doctor, doctors are not doing it as part of their daily work. So look at the implementation in Spain. This is a paper from 2021. There were 234 hospitals. They had a good response rate. The problems that they found: hand hygiene, communication, low reporting, poor antibiotic use. I only gave you some of the studies from this paper in Spain. So the problem is, we know what to do, but how do we implement it? That's the biggest problem. Now I'm on to the main bulk of the talk, and you're watching the time. How can we be safer? So here is the strategy. This tells you what you do. Am I correct? I got this off the website. It's the latest one. It tells you what you have to do. But how can you do it? My one critique of the strategy is that no one's going to read it because it's 170 pages or so, and a busy doctor's not going to read it in the front line. So you've got to think of strategies how we can do that. And it's not to say you're not the only one. In England, it's exactly the same. In Ireland, exactly the same. Lots of things that the health department comes out with that the frontline staff never read. They're too busy doing other stuff. They'll read their clinical journals, but they won't read this. So how can we get it to the front line? Back to the music. Then turn the volume up again. You can see them playing in unison. It's a beautiful piece of music. That's what we want to achieve. We want to achieve the beauty that Schubert has made. Okay? First violin, culture and leadership. The second violin is educate for safety. The viola is looking after our healthcare staff. If they're not happy, they cannot be safe. Bottom line, if they're burnt out, they cannot be safe. The first cello, these are actually the quartet, that the quintet, the fifth one is coming in, is measure and design for safety. And finally, the cello that has been brought in is co-produced for safety. So I'm going to take you on a journey with this quintet that you're going to see how important it is to be safe. Because remember, I told you, they don't know it, but they perfected human factors in their playing. The first violin. We must work with the why to get it right every time. You've heard the statement. Culture eats strategy for breakfast. We don't know who said it first. They say Peter Drucker, but it's not. Culture is the most important thing. If the culture of the organization is not right, you can throw as much strategy at them, it's just not going to work. Within the teams, if it's not right, it's not going to work. Because organizations are very complex. I love this train. What we permit, we promote. So if you permit, and I don't know if you do this, if you permit the WHO checklist, you know the surgical checklist? If you permit the surgeon to send someone junior to do the checklist, and the surgeon only appears to do the surgery, and you say, we've done the checklist, I'm sure that happens. Happens in my hospital. Then it hasn't been done. If you permit doctors to make errors in their prescribing, you're promoting errors in prescribing. If you permit poor hand hygiene, you're promoting it. Why do I say that? Because culture is about belief systems. What we think and believe reflects our values, which then tells us what we're going to do, and that will get us the outcomes. So if I don't believe I should be bare below the elbow, because where's the scientific evidence that doctors tell me? I say, well, you don't need scientific evidence to know you can't wash your hands if you've got sleeves down to here. Simple, but they'll say, where's the evidence? What we believe. We have to get people to believe that patient safety is the most important thing that they do while they care for patients. Not caring for patients, caring for them safely. This requires values, the values of the why. And here I've given you a few values that you could look at. Respect is the most important one, I think. Do we respect each other? And I can tell you, in tertiary care hospitals, there's a lack of respect often. Chris van Hecht was talking today, and must be on one of the other sessions, where he said his tertiary care quaternary center, that was picked up. Respect, courage to take actions, compassion and kindness and transparency. So these are some values. So you have to have values for safety. Then from Jim Reason, again I tribute to Jim Reason, who died recently. He's a Swiss cheese model person, but he died also earlier this year. We need a culture that is just and accountable, that's informed, that we know what's going on, that is flexible, able to change with changing circumstances, that's reporting and learning, the 5 pillars of your culture. Most cultures aren't this, and this comes from Jim Reason from many years ago. People have forgotten the 5 pillars of what a culture should be. And for the just culture, this needs leadership, from board to the front line. Those values, it requires reliability, continual improvement, but there must be accountability. Teamwork is very important, and of course, psychological safety, where people feel safe to speak up. Most healthcare organizations don't have that. Just reflect on whether yours does. What happens when something goes wrong? Do we open the books to the patients and their families? Do we say, you can bring your lawyers in if you like to look at what goes on? Generally, we close down. So, bit of reflection now. Where are you now? Pathological? Well, I hope not. This is again from Jim Reason. Reactive, we react when something happens. We have systems in place. We anticipate and prevent. And safety is our business. So I actually I've just come from Sao Paulo on British Airways, and the pilot, and I think he means it, says, we're here to keep you safe while we fly you to London. I was flying to London. Not we're here to fly you to London, we're here to keep you safe. And we just in co-production, remember, this is something for you to remember. When you're on the aeroplane, observe the flight attendants. On Air France, they're called sécurité, safety people. They're not called flight attendants, they're called safety attendants. You must observe, they're not there to give you food. They're there to keep you safe. I always sit in the exit row, not because of the extra leg room, to observe what they do, how they tell me to be safe, because I've got to open the door to see if they keep it clear, how they check the seat belts. You must observe this, because you can learn lessons on how to be safe. I anticipate that most of you are somewhere in the calculative zone. Some might be in the proactive zone. Now, you could test it with the Manchester Patient Safety Scale. Second violin, is education for safety. The failure to educate is why we're in the position we are. A study again from Spain, 2024. You can read the bottom line. We are not training the future generation. And Spain's ahead of the game. It's not part of the program, like pathology, anatomy. And when this was studied by the cost group, they looked at all the trainers across Europe. 27% said they had good programs. And that was led by the team from Spain. That's research. And we need to learn for safety, develop a learning system and a learning model. And this is very important to have high-produced safe care. This is a whole system of learning with a whole lot of things you could put in a different box. It's from a paper called If Patients Define Safety or Quality. And we need to educate. And here are a lot of papers on education. I'm showing that there's a lot of things on. And here's the curriculum that the cost group came up with educating for safety that you could implement now. And when I wrote the editorial for this paper, we came up with the idea that healthcare workers must be injected with patient safety into their genome, into their DNA from the very start. So this is what they do. This is just what they do. And to do that, they have to have continual learning, they have to have the skills, they have to have the culture, and it must be in their genome from day one of medical school and nursing college or wherever. From day one, they must be starting to talk about patient safety. It's not happening. It's an extra subject here or there. Let's get to the viola. The viola is about ensuring well-being for safety. Well-being for safety, well, this is the systems model from Pascal Carrion and her group from the USA showing that burnout is very common and that affects the patients, the clinicians, healthcare organizations. And this is often due to what I call the industrialization of healthcare, just like Charlie Chaplin. And the effect of that is that people feel powerlessness, lack of meaning, estrangement, isolation, enormousness. This was happening in COVID. This is work actually from Durkheim, Marx, and Weber from the 19th century. And poor well-being and burnout has poor safety outcomes, almost 2 to 3 times. And then we have to focus on the second victim. And this is the work from COST, again led from Spain. So Spain's been a leader, as you see, I've been referencing, been a leader in many things. And this is Jose Maria did this as well in his group. You were on that as well. So I went there quickly because I've got only 15 minutes left. The cello is designing it, is making safety our business. Making safety our business. So these are the OECD countries, and I just wanted, this is to make you feel good. So this is what you all collect, these data. And Imperial College published a global report of patient safety. They made a composite measure of these 4 groups: maternal mortality, treatable mortality, adverse medical events, and neonatal disorders. And Spain is number 9. It's pretty good, but you want to be number 1. You want to beat Norway, don't you? So I don't know if you've read this report, but it's very useful to see Spain's doing very well. You see the UK is that little red bit down the line, but you can see who you're doing, and you've got your strategy to do that. So what you have to do is identify what works. This is implementation science. We have to move to implementation science. Identify what works, You've got the generalized knowledge, you've got that already. Now you have to apply in different contexts around the country, because what works here in Madrid will not work in Barcelona, etc., etc., etc. And then you have to learn and feedback and go on the cycle again. So that's what we have to do for implementation. And here's another way we can do it. You have your intervention, the processes, and then you have all these other things that happen. The outer setting, that's ministers. The inner setting, that's the organization, and then the individual. And their readiness to change. So implementation science needs to meet us in patient safety science, which just hasn't happened before. They have their own conferences. And this is putting together on one page, improvement science one side with all its methodologies, Lean, Six Sigma, model for improvement. Here's another method of the implementation science, and there's the patient safety science, the human factors. These must all come together if we want to be safer. So we have to make it easy or easier. Because what happens is the variability that happens one day for good care does the same thing, creates bad care the next day. So that's from Eric Holnagel. So we have to learn. I know you've got a reporting system. This is the one in the UK, like an accident reporting system, investigates with no blame as the aim. And this is the latest London protocol from Charles Vincent and his work. It's useful to read, even if you're not using the protocol, because they're introducing new things on how to investigate in a no-blame way. So it's useful to look at and looking at good care as well as problems. How do we get it right some days and not others? And you have to learn from excellence. That's very important. I've got that already. And this is the program I run, and I think this is maybe the answer. It's understanding your risk prospectively, reliable processes, introducing SEEPs and the human factors, and enhancing resilience. So this is a program we call SAFE, Situation Awareness for Everyone. I've run it across a whole host of hospitals in a number of countries. This is one of the papers that came out of it. It must become part of what we do every day. And here's the funders, 50 hospitals across EU. In Ireland, we have over 100 teams we've trained in a small country of 5 million. So it's smaller than Madrid, I guess. But we have trained these people, and done in Sudan, Mozambique, Australia, Argentina. Here are the papers. And there's 6 things you do. It's based on the huddle idea, but the huddle is just the tool. You identify who's at risk for whatever. You come together to talk, you mitigate, and then you escalate. You're predicting what goes wrong. It's from reaction to prediction. And there's 6 steps. What do we do well? Every day, the clinical teams are saying, what are we doing well? So we can do it again. What worked well? How do we prevent people fall? And then they say, because they've got all that resilience in them, did we harm anyone in the last 12 hours, 6 hours, 8 hours? Not the last 3 months. That's useless knowledge. You can't drive the car looking in the rear view mirror only. You have to look in the forward as well. They do a 5-why root cause analysis, fix it. Then they ask, are we doing what we're supposed to do, what we've agreed to do? And they use reliability theory. Then they do the SEEPs model. Are we safe right now? What are the risks? Will we be safe in the future? Who may fall? We get the teams to define what happens where we work. Do people fall here? Do they get delirious? Do they have pressure ulcers? Whatever it is in where they work, care of the elderly will be different from an ICU, which will be different from an obstetrics unit. They define what the risks are. Then they're starting to predict what might happen. And then they ask, most importantly, are we learning? So reliabilities, the 5 reliabilities, I'm not going to spend time on them. And deference to the front line is very important. Expertise. They use care bundles. This is from an ICU. They use the SEEPS model, looking at the tasks and the tools and who needed things. And then they predict the future. This is just for deterioration. They're predicting the future. Who may deteriorate, who may fall, who may whatever is the harm that they get. This is one team. Volume up. Time okay. Imagine if all your clinical teams were producing something like that. We asked them just to make a video of what they did, and that's what they did. But that was another, that intense team I had from there. Then we have safe telehealth, which is the new challenge, as I mentioned earlier. We need to think of the ways we're going to make this safe. And here are some of the things we have to do: the human factors, diagnostic accuracy, psychological and emotional safety. We have to have safe artificial intelligence. Very important. And this is where it is going to happen. We use this already. The co-produced one is based on the charter from the WHO on patient safety, and it aims to co-produce safety, where we co-assess, co-decide, co-design, and co-deliver with people patient safety. And this is the latest stuff that's coming out of Paul Batalden, is where the professionals prepare, the patient prepares, and we go through this process of listening, shared planning, and delivering a service or a product. And the service is what we want. So now we get on to some of the fun part, because I'm going to illustrate it with my own lived experience. So I happen to be a patient right now. I don't think I'm a person who so happens to have stage 4 prostate cancer. And this is all about dancing. You know the song, those who are old enough.
Put on your red shoes and dance the blues.
You remember the song?
Dance to the song they're playing on the radio.
Think about this. When I got diagnosed on the telephone, my Family doctor said, the PSA is a little high, 5.1. I said, okay. She said, we'll put you on fast track for MRI, 10 days. That's the NHS working. MRI done just before Christmas. And 10 days later, phone call, telemedicine. I'm doing telemedicine. Because at that stage, I was on holiday in France. I was never expecting to have an abnormal MRI. And the urologist said, you need to have a biopsy. Now done by a nurse, 10 days later, just after New Year. And then they do a PSMA scan that tells me I have stage 4 cancer. So I want my treatment. And this is what I want. I want to have a waltz. Peaceful treatment. I have aggressive cancer, stage 4. I don't want chemotherapy. I want quality of life, not quantity of life. And I want to self-manage my care. This is my music and my dance. I'm still only seeing nurses. And then I go to the oncology clinic. This is their music. Stop the music. I'm not interested in staying alive. I want a service and a product. The product was staying alive. This is what I want. Because I know of the side effects of the medications, the complications. As a patient safety person, I definitely know a lot about this. So we came to a co-production and we came up with new music. We had to learn to do the cha-cha-cha together.
Come fly with me, let's fly, let's
Which is a far better way of doing it than just staying alive. Using all these theories. I had to teach my doctors what to do. So it's all about dancing. It's all about dancing. Before I play this, it's all about dancing. What I'm trying to say here is that patient safety is about the time, that magic moment, when a healthcare provider, doctor, nurse, radiographer, physician, psychiatrist, whoever it is, meets the person we call a patient. At that point, safety is made. And you have to do it together. You have to dance with the patient. The problem is, the patient only knows their music. We as healthcare providers need to know a lot of different music. That's the complexity. So when I come in here, I'm not saying to Susanna, I don't know whether to tell the story or not, and I want to talk about dancing. I thought we need to do a bit of dancing just to lift us before we end. So, show me how this moves on. Come, we are dance.
Salí de casa con la sonrisa puesta. Hoy me he levantado con todo de verdad.
So, I could dance forever, but the message, 5 messages. You've had a bit of fun. We have to change our culture. Education at the start. Essential. We need to figure out how to implement. We have to integrate all the theories, and we have to learn how to dance with the patients. So I want to thank you for inviting me here and to listening to my story. Thank you very much. As you move out, if we have questions now, just listen to the second movement of this wonderful quintet. Volume up slightly. And then we open for questions. Thank you very much. Just in time. To the heart. Just think about it. If we can achieve this with our patients, the people we call patients, we will be safer. Listen to this. And watch what they're doing as they create the beauty of this music. First violin, and then the others will respond to him. Because he's culture. Remember, he's the culture. But they're all playing together to produce safety. If there are any questions, you can ask in Spanish. I have a very good translator over here, Susanna. Thank you.
There are no questions here. No questions from the... ¿Alguien quiere hacer alguna pregunta? Estamos justos de tiempo. Yo tengo una lista tremenda. Le hemos pedido que escriba un editorial para un próximo número de la revista y ha aceptado. So we will have a summary of what you said there. Yo al menos me voy con un montón de deberes que reflexionar. Muchísimas gracias, Peter. Thank you so much for coming and for this, for showing us your experience. Thank you.
Thank you very much.